All right, good morning. Um, we wanted to welcome you to this morning's webinar, Caring for Newborns Impacted by Substances, Tools to Support Parents and Caregivers. So we'd love to get started with some introductions. If folks want to introduce yourselves in the chat, if you want to share your name and your role and where you're joining from, we'd love to get the chat going this morning. My name is Adrienne Gerard. I'm the director of the training and technical assistance team for First Steps Together. And I'm going to do some quick housekeeping, talk a little bit about First Steps Together and our resources, and I'll hand it over to our presenter this morning. So just some quick housekeeping. This meeting will be recorded and it will be available publicly. We'll send out a link to the recording and all of the resources after the webinar. We'd love folks to mute when you're not speaking, but please feel free to unmute to ask questions. And we'd love to have folks use the chat throughout. You can ask any questions there, have any discussion, share any information, and we'll have a question and answer session at the end. For those who are not familiar with First Steps Together, it's a home visiting program dedicated to serving and empowering families on their parenting and recovery journeys. We have 7 sites across the state, and we serve parents and expectant parents who have been affected by substance use. We offer voluntary and free services in the home, community, or virtually delivered by a peer support specialist, a family recovery support specialist, who is a parent in recovery or a mental health counselor with specialized training. We also offer groups and care coordination. First Steps Together is open to any person 18 years of age or older who has ever used opioids, stimulants, alcohol, cannabis, or other substances in the past or present, and who is pregnant or expecting a child, or has at least one child age 5 or younger. So this slide right here has our map, which shows our 7 sites, as well as a contact person for each site. And all of this information is available at our website, www.firststepstogetherma.org. And we can throw that in the chat. So I'm the director of the training and technical assistance team, and our team provides support for the staff across our sites by offering trainings, developing resources, facilitating learning communities. And in addition to supporting our own program staff, we love and aim to create systems change by partnering with other providers to share resources and trainings that promote best practices to strengthen and expand this specialized workforce. So we recently released Taking the First Steps Together, a guide for creating collaborative peer-led services for parents affected by substance use, along with the First Steps, My Family Portfolio, which is a workbook created by parents in recovery for parents in recovery. All of that is available at our website, firststepstogetherma.org. So before I hand it over to Amy Summer, we just wanted to share some reminders. So first, some topics might bring up some feelings or experiences. And so above all, we just want to make sure that you take care of yourself. If you need to take a break, please do so. Again, we'll send out the recording so you can watch anything after. The information that we shared today is what we have found today and what we know so far. We know that everything is always changing, and we welcome conversation about this topic, and we're happy to hear others' experiences in the field. We also recognize that accepted languages and best practices are ever evolving. And finally, as presenters, we aim to create a brave space for diversity, equity, inclusion, and we expect that others will be willing to engage in this way. So now I'm really excited to hand it over to Amy Summer. Amy Summer has been providing services to parents and young family for almost 20 years. She's trained in interventions to treat trauma in young children, including child-parent psychotherapy and trauma-informed cognitive behavioral therapy, as well as a trainer for Mothering from the Inside Out, which is an evidence-based intervention to support parents impacted by substance use. Bringing today her good fortune to have worked on 4 nationally funded evaluation projects treating parents and children. She's going to share a wide base of experience with this group. So I'm going to hand it over now to Amy. Thank you so much for being here.
Thank you so much for having me. I'm so excited to be here this morning. And one of the things I want to start out by saying is that I'm here really to walk us through some thinking today, and I'm doing it in partnership. And even though I'm the person that's going to be talking this morning, I wanted to thank 3 colleagues of mine who really have gotten me to where I am in my learning about this. Well, 4, one of whom is our fearless leader. So Deborah Berkovitz is the statewide director for First Steps Together. And it was at her invitation way back in 2009 that I came together with some other folks who were thinking about how to support parents when they were caring for infants, when those parents had been identified as having opioid use disorder. And that's really kind of what the focus was in 2009 was, oh my gosh, we have this opioid crisis and we've got to help these parents and we've got to help these babies. So first I want to say thanks to Deborah, and there were 2 people who really joined with my thinking and speaking that day who I really want to call out. One is here and one is not, but Christina Russell co-presented with me. Many of you know Christina as our fearless leader of our Cape Cod site. And Christina and I said, Christina in particular was like, I've been watching babies for a long time. I've been watching babies get discharged from Cape Cod Hospital for a long time. And there are some things I think we can say about when babies do well. We want to talk about that. We want to talk about what do we notice when things are going well. So Christina co-presented with me that day, and there are still elements of these slides that I really credit to her and her shared thinking. And Christina and I were in the audience, and we got to see an amazing presenter who was and is a parent herself talk about her own journey in parenting. And we all know her and love her as Erica Napolitan. She had a different last name then, but she was someone that I watched speak and really inspired me, and had the incredible good fortune to then go out into the world and present with Erica. And again, I want to say there's content in these slides, phrases that I use that really are credit to sharing a brain with Erica and the way that we think about supporting parents and infants together. We had the opportunity in 2013, 2014 to be part of the Vermont Oxford Network's national learning on how to support parents and infants impacted by substance use. We got to go on some fun trips and talk to a wide audience nationally. And it's sort of lovely to see that now here we are in 2023, and some of the things that we've been talking about are evidence-based practices and best practices. So just really want to thank those 2 folks. And lastly, my colleague, Danya Handelsman, who's here with me at Jewish Family and Children's Services. We often present on thinking about caring for newborns together. She's at a training today, so she's not able to be here. But again, just really want a testament to the power of shared thinking. And I hope to use that to lead us all into our work today, because we are going to come out of this webinar better, like 23 slides later or something, if we think together. So please use your voices, please ask questions, please chime in. If I can do this presentation with 3 people's thinking in my brain, I know that we can improve our thinking even more if we think together. So what are we here to think about today? So we want to really think about providers, and in this case, I mean you all, every last one of you, in supporting families when they are caring for an infant who may have been impacted by exposure to substances during pregnancy. We're going to talk a little bit more about what that means and why we're using those words. But we want to help families feel better, do better, and reduce harms. And one of the harms that we're talking about is when infants and parents are separated from each other. So we want to be doing those things better. And we're going to use the tools in this research and in this literature to think about how specifically we can support families better. That's our job, right? Oftentimes we're supporting parents and helping them to support infants. Sometimes we may be supporting infants directly, but we really want to be thinking about what we know in order to do our jobs better. So I hope you come out of this webinar today with an idea, a plan, a hypothesis, a little inkling of something that you might do differently in your work. And I invite you, as we sort of do this, think about the families you're serving. Think about a family you've seen in the past. Think about a family that just got referred to you. Have someone in mind as we're going through this webinar. Think about how this language, these tools might land for them. Think about, if you're new to this work, what I hope to try out with the families I'm going to support next week, next month. Really be keeping folks in mind as we're going through this so that you can think to yourself, is this going to work? What's going to need to change? And that's the part where we participate together, right? That's the part where you say, Amy, I like that idea, but that would never work for this family I'm thinking of. And here's why. Because then we all get to be better providers as a result of that. So what specifically do I hope that you'll walk away with today? As I said, we're going to talk a little bit about terms and definitions. Just think about what we say and why, how that impacts people. We're going to look at 2 different evidence-based practices to really support caregivers to meet infant needs. And there's a few reasons for that. One is to be biased. I like these evidence-based practices, but the other is I feel like it gives us as providers a little bit of backbone, right? Like we're teaching parents what the evidence says is the very best thing to do. Science has gone out there and done all these studies and all this research that frankly, we don't always want to be doing the data collection and doing the 8 million questionnaires, but other people have, and we can borrow from that. We're going to take a look at the First Steps Together family portfolio. Just notice where that portfolio also ties into supporting our work, helping us do this well. We're going to talk a little bit about resources in our communities, as well as what we might want to offer caregivers when we're thinking about parenting older children. So this webinar is really focused on the care of very, very little ones, newborns and little babies. But the weird thing about little babies is they grow up. And then we want to know as well how to continue to support them. And we know that that's part of the role here at First Steps Together. So those are our goals for this morning. And as I said, we're going to start by coming together to share a little bit, hopefully have a little bit of common language when we say, what are we talking about? And even in the title of this presentation and in the learning objectives that I just shared with you, we've used the phrase substance exposed newborn. We're going to go over what exactly do we mean when we say withdrawal, addiction. What are we talking about when we say exposed? What does it mean if a substance impacts someone? What is a drug? I'm not going to go into all the dictionary definitions, but I am going to take some time now to invite us to work together on coming to some shared language and considering how our language might impact the people we serve. Because again, if our goal is to do better by the people we serve and to become better providers, we might want to start by thinking about how things are landing, how things are heard. So I am going to take a little bit of a risk here. I'm going to invite people to unmute and to holler at me some synonyms, some similar meaning words for exposed. What do you think? If I was to use exposed in a sentence, what does it mean? I'm not going to call on people. It's a little hard with the visual. So please, I invite you to just holler.
Infected.
Infected. Okay, great. Yeah, like I've been exposed to tuberculosis or something. Thank you.
Vulnerable.
Vulnerable. Yeah, I'm feeling exposed.
Not protected.
Yeah, without protection. Thank you. One more.
Affected.
Affected. So exposed could mean like I was exposed to this particular content and it affected me, right? You all have been exposed to this webinar this morning and maybe it will affect you. Thank you. So I could be infected, affected. I could be without protection, vulnerable.
Revealed.
Say that one again.
Revealed.
Revealed. Yes, thank you. The first one that comes to mind for me is like naked. Like I'm just out there all raw. So I really appreciate these. So when we're saying substance exposed newborn, we're using a lot of language that, maybe other than affected, meaning like, I was exposed to this new taste or I was exposed to this new language, but most of the other words are pretty negative. So wanting to think about, as providers, if we're saying this infant already, we're saying something a little unprotected, without protection. Is that the best way to think about a baby who's come into the world? I'm not saying right or wrong, and I don't have a definite alternate proposal, but just thinking about that word exposure and whether we might want to think about how we're talking with families. Maybe we want to use the word impacted. Maybe we want to use, there were substances present during the prenatal period. What might we want to shift? It's a question to think about. So then I want to think about, well, what do we mean when we say substances? Because that's kind of the technical term, a substance exposed newborn. And I'm going to read you guys what the federal law is, and then we're going to go actually over our Massachusetts language as well. But when I say to you, what does it mean to be affected by something? What are some just regular person words for that? What does it mean to be affected by something?
I would say
Bother. Bother. Uh-huh.
Maybe harmed?
Harmed. Okay, yeah.
impacted.
Also means impacted, yeah. Couple more.
I would say vulnerable.
Also vulnerable, uh-huh.
Like it changes you somehow.
A change. Yeah, I love that one. That's what I think of too. Like, oh, something changed me, right? And again, hopefully this webinar affects you all and affects your caregiving, but it could also be something negative, something in the environment that happened to me. So just want folks to be, part of what I want folks to recognize in that is the wide variety of definitions. So we use this one term when we're in like literature or science or talking to doctors or, substance exposed newborn, newborn impacted by substances, but listen to the wide variety of meaning that those words have for us and thinking about how can we get more specific about what we're saying and why we're saying it. Couple of terms to go over just because you'll hear them used in some of the videos, and it might also be helpful to think about. We're talking when we're talking about infants, usually we're talking, when we say substance exposed newborns, we're talking about newborns who are actually withdrawing from a substance. And that can seem sort of a little counterintuitive. Like we're talking about the substance, but actually most of the symptoms that we're talking about, most of the reason that we're wanting to give infants a little bit of extra support through their caregivers is because of the symptoms of withdrawing from that substance. So withdrawal just meaning the absence of something in our system and the changes in our system that can go along with that. So if I am used to eating a Cheez-It every day, and then on day 90, I stop eating Cheez-Its, I'm probably not going to have any withdrawal symptoms. But if I am used to having caffeine every day, and then I stop drinking my coffee, I am going to have withdrawal symptoms. So we can take something every day, and stopping taking it may or may not affect us. And it's that stopping taking effect, that withdrawal that we're talking about. I'm just sharing that again to kind of think about how we talk about infants when we're talking about sort of this thing that happens that we need to intervene on. We're actually talking about an infant without a substance affecting them. It's just, what if we really thought differently about how we're talking about what's happening to the parents and the infants we care for? Sometimes where I work still, I hear the phrase, oh, we work with newborns who are addicted to, let's say, opioids. Newborns are never addicted to any substance. Addiction involves a physiological state, but also a psychological craving, a preoccupation with using substances, and causing harm to ourselves when we are using those substances. No infant is addicted to a substance. Again, their body may have some physiological dependence, and they may show us that physiological dependence was there when they withdraw from the impact of those substances. The last point I want to make here is that when we're talking about substance exposed newborns in kind of legislation and policy, we're usually talking about substances of misuse, substances which can be misused or cause addiction in adults. But there are lots of substances that impact newborns, and I'm going to flip the slide, but I want to tell you this is what the federal legislation language, and again, I just really want you to listen to what the words are and if we really know what they mean. Federal legislation says that child welfare in all 50 states, in order to continue to receive funding, must have provisions that address the needs of infants born and identified as being affected by substance abuse or withdrawal symptoms withdrawal symptoms resulting from prenatal drug exposure or by fetal alcohol spectrum disorder. And we'll get a little bit more into that. But so at the federal level, we're requiring states to do things when they know that infants are affected by substance abuse. What does that mean? What does that include or not include? Or the infants are withdrawing because of drug exposure. It doesn't say drugs of abuse or misuse. It just says drug exposure or fetal alcohol spectrum disorder. So I want you guys to hold that in mind as we look at this chart. Here are some substances: tobacco, alcohol, opiates or opioids, and SSRIs, which is a class of antidepressants that includes Prozac, that includes Zoloft. So very common SSRIs are medication for depression that are often used to treat depression during pregnancy as well as before and after pregnancy. And I'm going to walk us across this chart and just have like these questions about what happens to babies who are exposed to these things, what might happen, what do we know, and what do we call this? So if we look at tobacco at the top line here, tobacco is known to cause neurobiological behavioral effects when infants are exposed to it. There are ways that infants behave differently when they've been exposed to tobacco. I wrote testable. That's not quite the right word. You can test for tobacco use, but we don't test for tobacco use in parents, right? When a parent is growing a baby inside them, we don't test for tobacco use. We often ask people and they might tell us if they were using tobacco or not, but it's not something we routinely test for. And rarely in the literature are infants impacted by tobacco use alone labeled substance exposed newborns. And if we go back to that CAPTA definition, that we're supposed to be doing things required by the government when infants are impacted by drugs, when infants are impacted by drugs and withdrawal, and we say, well, we're supposed to be doing this for all parents. I don't think you will find any of the 50 states that are doing this for tobacco use. And I'm not here to say that we should be. I'm not here to say that we should do things for moms who are using tobacco, but I am here to notice that I think we might do better in our care for families when we use the words that mean what we want them to mean and say what we want to say, instead of sort of using these funny, blurry terms like affected and drugs and not really sure what they mean. I'm going to sort of lump the next two together a little bit, right? Alcohol use, we can test for in parents, we sometimes do, but it's pretty rare, mostly because alcohol is metabolized so quickly that if you're coming in even for weekly prenatal appointments, there is certainly lots of alcohol use that can go undetected. We often test parents for opioids, right, when they're pregnant, especially if we know that they have had an opioid use disorder diagnosis, or if we know that they are using medication for opioid use treatment. So lots of testing for opioid use. And those are the babies. That's the only one. If you look in this column labeled substance exposed newborn, those are the ones that always get the yes. So interesting to think about. Some hospitals are starting to think about classifying babies as substance exposed newborns when they have been exposed to SSRIs and maybe experiencing withdrawal from that. We don't typically test moms. We may ask moms, are you taking Prozac or Zoloft during your pregnancy? But something to think about in terms of how things get counted and reported. So just to narrow it down to the state of Massachusetts, since that's where we are practicing here in First Steps Together, though we certainly welcome any listeners from other states. In the state of Massachusetts, we have chosen to define substance exposed newborns as a newborn who is affected, there's that word again, by maternal dependence on opioids or benzodiazepines, and to newborns affected by maternal use of drugs of addiction or showing symptoms of withdrawal from maternal drugs of addiction. So now we've actually said in Massachusetts, we're actually not going to talk about SSRIs. We're talking about drugs of addiction is the word that's used, or, and a special focus on dependence on opioids or benzodiazepines. So again, just really interesting to think about sort of what gets included and not included in that when we're thinking about counting numbers, when we're thinking about who's impacted by state and federal policies, including policies of notifying our child welfare systems, right? And we could do a whole nother webinar on sort of what happens when this definition then gets applied to, so should we be notifying our child welfare system about the existence of this newborn and why or why not? We're not going to focus on that today. What we're going to focus on today is how to best care for these infants. You're going to hear, I'm going to use the word mom, dad, parent, and we will get into welcoming, loving caregivers of any variety, grandparent, auntie, best friend, next door neighbor, but just want to name that we're really thinking about the parents who have given life to this child and how we can support them in this webinar. So you might be thinking to yourself at this point, well, if this lady's sitting here like questioning what is even a substance exposed newborn and why do we talk about it, then how's she going to give me a webinar on how to help parents care for these infants? And the bottom line, as I see it, is that when babies are neurobehaviorally impacted, when they're having differences in their developing brains and bodies and behavior related to any substance exposure, I don't know what it is. I'm certainly not in the business of drug testing parents to find out what it is. But when they are, one of the things they struggle with is feeling content and feeling calm and feeling soothed. And the thing is that we know, and again, the great news is we have the research to tell us that caring for a difficult to soothe newborn is really hard and can result in difficulties. So that's where I sort of link these things together. Is I don't necessarily, you can take the whole rest of this webinar and think about a difficult to soothe newborn, if that's what works for you, because I am not in the business of having parents pee in cups before I work with them. So these are just two examples of nationally sort of available campaigns supporting parents in really understanding how to support babies who are fussy, babies who are crying. The campaign on the left there, All Babies Cry, came out of Children's Trust Fund and Healthy Families, and really understanding that when a baby is crying, there are things we can do. I love the phrase right there, to comfort your newborn and yourself. So really the importance right there, anytime we have a fussy baby, of thinking about how to care for ourselves and how important of a role that is for us as providers. On the right here, the period of purple crying is a national intervention really looking at reducing public health costs by helping parents soothe their babies, often focused on colic, which is around 6 to 8 weeks of age, can tend to kind of come up. But these are sort of the common signs of colic. The reasons you might think of colic: happens in the evening. It kind of can come to a peak, but be unexpected. Babies get almost like, grimacy and scrunch up their faces. So all of these are signs of sort of what might be considered a colicky baby. But I love the phrase at this one at the bottom. They call it, the intervention is period of purple crying. And at the bottom here, it says the word period means crying has a beginning and an end. This will get better. And that's, specifically, again, this campaign was focused on colic, but it's true for all babies. I have not met a 7-year-old who cries for hours and hours and hours and every 5 minutes, and no matter what you do. I've met 7-year-olds who cry. I've met 7-year-olds who are a little difficult, but I have not met a 7-year-old who cries like a colicky baby. So helping parents remember and helping us remember that this can and will end is a part of what I think is important when we're talking about care for substance exposed newborns. So we're going to get to the two very specific, let me move my little slide here. We're going to get to the two very specific interventions for or particularly thinking about substance exposed newborns in just a minute. But before we do that, I'm going to introduce a concept that I think is really important and connects this idea of like helping an infant who is fussy or having a hard time settling, no matter what we might know from that blue chart that I had about which substances they were impacted by or exposed to or were in a parent's system when the baby was born. And the reason for that is a really great concept developed by people with disabilities called universal design. And what universal design means is that we should design things in our world universally all the time in all the parts of our world to help those people who might need a change in design the most. So, sorry, I just need to close that. So I have on our slide here 3 examples of universal design. I'm certainly open to people throwing other ideas out there. But when we talk about universal design, we're really talking about things we can do that don't hurt anyone, but help some people a lot. Okay, so on the top left there, we have a curb cut, that yellow curb cut. So that helps people who are using mobility devices, whether that be a walker, a wheelchair, a baby stroller. And it doesn't hurt anyone. Nobody walking along that sidewalk is like, oh God, there's a curb cut. That's really going to ruin my day. On the bottom left there, we have Braille symbols or markings on a number pad. Again, super helpful to someone who's vision impaired who needs the Braille to be able to use that number pad. Doesn't hurt the rest of us. We just go and press the numbers that we can see and carry on with our day. And that hand railing on the right there, I actually joke about this one, helps people with mobility issues, balance issues, visual impairment who need a structure as they're going downstairs. Doesn't hurt the rest of us, although then I'm like, I'm really clumsy, so sometimes I've been known to trip over railings or things, but the principle is there. These are things that we have put into our world, and my guess is none of you really notice them. None of you, probably most of us, don't walk around thinking, oh, I need that, unless we are a person who is impacted by what this design is trying to help. So if you're a visually impaired person listening to this webinar, you're probably like, I notice exactly where there are and are not hand railings because it makes my life easier or harder. I started noticing the curb cuts in my town when I had a family member in a wheelchair. And all of a sudden was like, this block is really easy to walk down and this one is nearly impossible. So I'm inviting all of us to go through our worlds with the families we support, looking for the places where there's universal design, where it makes it easier to care for a baby, maybe especially a fussy baby, and the places where maybe we are missing some universal design, and to think to ourselves, what are the things that we could advocate for or add that might help the babies who need it the most, and certainly aren't going to hurt any of the babies who are just going along living their best lives. We'll point some of those out. They're going to come up in the next, in one of the videos that we watch, but that's a lens that I want us to all be bringing with us. Oop. Oh, I'm sorry. I just clicked on something. And here's the great news. Again, doing this, noticing this, it won't hurt anyone, but it can really help the babies who we want to help. And it doesn't matter whether their difficulties were impacted by who they were, their brains, opioid exposure, right? This curb cut, it helps someone in a wheelchair no matter why they're in a wheelchair. That railing helps someone with balance difficulties, whether they have emerging Parkinson's disease, whether they have vertigo, whether they're impaired by a substance and needing a little extra support, it doesn't matter. And that's what I'm hoping to think about as we think about, you don't necessarily need to know exactly what substances are involved as providers who we are in supporting families. So what is it that we're going to do? What are the evidence-based interventions that we're going to take a look at? And again, we're looking at these sort of a little bit out of context. We're going to look at 2 evidence-based interventions, and you might be thinking like, well, I'm not going to get trained in that thing, and you're not, but you're going to use the tools to support the families who you serve. Here we go. So the first intervention we are going to talk about is called Eat, Sleep, Console. And we are going to watch video, so I'm not going to spend a lot of time explaining it, but I'm going to go over just a little bit of the philosophy so that you have it in mind as we watch the video. And then we're going to take some time and have some breakout rooms to really talk about how might we take these tools and use them in our home visits and our conversations with families and the ways that we're supporting the parents who we see. So the philosophy of Eat, Sleep, Console, as you'll hear the doctor who helped create it talk about, is really, what if we treat this baby like a baby? What if we look at the baby in front of us and think about what all babies need? He's really talking about universal design. He doesn't use that concept, but it's a real foundation. And this is how he came to it. He said, babies need to eat, they need to sleep, and they need to be consoled. And he kind of cracked a joke. He's like, yeah, we worked really hard on the name, Eat, Sleep, Console. It was like, hours of brainstorming. We're going to watch some clips from a video, but I'm just going to give you a little bit of the context that you're going to miss. This doctor was working in neonatal intensive care nurseries, and he started digging into the data about what happens to babies. Again, this was focused in the early sort of 2010s and 2010s around what happens to babies whose mom has been using opioids during pregnancy. He's like, some of these babies go home after 10 days in the intensive care nursery. And some of these babies go home after 33 days in the intensive care nursery. And some of these babies go home after 60 days in the intensive care nursery. And what he said, and he's a doctor, I have no idea if this is true, but he said that doesn't happen in any other illness. Like, you don't have babies with people with the exact same diagnosis and the exact same challenge. And some of them are fine after 8 days and some of them are fine after 30 days. Something's different here. Something's not quite being understood. And what he came, spoiler alert, what he came to focus on is that what's different, what seems to really make the difference, is how much babies can receive the kind of care that babies need. Just babies, not particularly worrying about what's happened to them or why, And one thing I'll say, again, that's in the video, but we're not going to see, but for those science nerds among us, because he got all this funding to do all this research, he was able to follow these babies for a really long time. Well, long in research terms. And he would follow them up until they were 3 months old. And he found that using these ideas at even up till 3 months postpartum, and after 3 months after these babies went home, they did just as well as babies who had all kinds of fancy medical interventions. So again, this is a good universal design. It's not hurting anyone. 3 months postpartum, everyone's still doing great. It's not like, oh my gosh, they didn't get this medical care and now something terrible is happening. I will say that in recent summaries, this research has been kind of noted that this is hospital-based evidence. This is a hospital-based practice. Again, I'm not saying that we're going to go into hospitals and do these things, but I do want to note that in hospitals, it has been found that it is less likely to be offered to non-white parents, that there are racial disparities in the way that this care is being delivered. That is true of all medical care in our country, but I just want to note here that if you are supporting a parent who identifies as non-white, it might be helpful to be noticing for yourself that it is less likely that they be offered this kind of supportive care, and just to be thinking about what you might want to do to advocate to notice that and to take care of yourself as well as that comes up for you. So this is the video that we're going to watch. We do have the link available. So, you know, if folks are interested in watching the whole, it's about an hour long. You certainly are welcome to, but I am going to switch over screens here and bring up our video so that we can watch it together. So that'll just take me a second here. While I'm doing that, if anyone has any questions or comments that they'd like to jump in with, that would be a great time. Okay. All right. So this is Dr. Matthew Grossman, and I'm going to just jump to the correct point in our video here. And again, as you're listening to this, you're not thinking to yourself, well, how am I going to change the birthing hospital down the street when I don't even work there? But I do hope that you might be thinking to yourself, what might I be able to do to support a parent? We're going to watch about 10 minutes of video total. I'm going to jump around a little bit, and then we're going to have time to discuss in some small breakout rooms. So really invite you, whether you are a note taker or a listener, listen to Dr. Grossman, notice what it is and how he's talking about the families that he supports. Again, he was a neonatologist. He's not an addiction specialist, but he was like, I'm getting told all this stuff about what I'm supposed to do for these babies, and I think I can do something a little bit better. So I'm going to put it to the right place here and press play and hopefully go to full screen as well.
As if they were like a baby and a mom. And it actually went okay. It actually went better. It seemed to be a better experience for both of them. And so we thought, that seems just crazy enough that it might work. And so we tried to do that a little bit. So we really started to focus on this non-pharmacologic care. So
I'm going to pause this for just 1 second because there's one thing I forgot to say. You're going to hear him use this word non-pharmacological care. Pharmacological just means like actual medicine, you know, like pills or chemicals or stuff that you'd cook up in a pharmacy. So when he says non-pharmacological care, he means any type of support or intervention or anything that's not strictly medicine.
we can do this. We can try to we have these kids for most of their hospitalization. We can put the baby and mom together, and we can really focus on these non-pharmacologic things, which, you know, I think we maybe said we were doing but weren't doing as well. So we wanted to create a low stimulation environment. We wanted to make sure we could hold the kids. We could feed them on demand, which we had always done feed on demand in our NICU, as long as the demand was every 3 hours. If it was anything other than that, it didn't really work. So we said it, but has anyone ever heard that a baby is not due to eat yet? I don't know what that means. So I don't know, has anyone had a baby before? And do you remember when they were due to eat? It was when they were ready to eat. But not in the NICU, it's every 3 hours. And if they manage to land on that, then great. But she had some hungry babies. So we could feed them on demand, wanted to hold them, be able to jump on. There was actually two things that we found that we really couldn't do as a staff that these kids needed. One was feed on demand. There's a reason that they are fed on demand every 3 hours, because if you're taking care of a bunch of other kids, you need a schedule. So we joke about it, but I don't know how else to do it if you're supposed to be doing other things. And so if your only job is to take care of that baby, then you can feed the kid whenever they're hungry, which sometimes is every 20 minutes. And the other thing is when they start to going. When they start to cry and get upset, you need to be there right away, within seconds. And so if you have 4 other kids and you're giving meds to that one, it's often 20 minutes before you can get there. And so the only person or people who could actually do those 2 things were somebody whose only job was to do those things. And that's none of us. That was going to be a parent, and usually the mom, but not always. So we started to realize, okay, so what we need to, if we're going to do this, we need to get the moms and dads to be there. And so that's what we did. And what we found is just by doing that, our length of stay went down from 22.5 days to 13 days, which is, so I don't know if anyone, so you can think about what your lengths of stay are for your places. So that was it. So imagine that was a medication that we said, oh, we just started giving this medication and we dropped the length of stay that much. We'd all be using that by now. But it wasn't a medication, it was mom. But we started to say, okay, well, let's just think of it as a medication. Let's think of mom as a medication and have that mindset. So we thought about, okay, so if you have pneumonia, mom is the antibiotics. So we just had, that's our first tenet of how we started to care for these kids. Mom is antibiotics, or if it's asthma, mom is albuterol. If you're in a non-neonatologist, you guys don't really do, neonatologists don't really do asthma, but pneumonia, mom is the antibiotics, okay? So we go with that mindset. Okay, next. All right, so then we said, okay, these kids always go to the NICU. For us, they would go straight to the NICU. Does anyone manage these kids anywhere other than the NICU now? Good, we got a couple, good. So why do they go to the NICU? Well, the reason they went to the NICU in our institution is because, well, that's where we always put them. Even though, like,
I'm gonna pause it there. He goes into a little bit of a sidebar here about sort of why the NICU. He talks about possible risk of seizures from withdrawal. And for those who are interested in the medical nerdiness, he actually then goes into explaining why that's basically, first of all, it's not actually a very big risk. And even if it was a risk for seizures, he says, which I kind of like, he's like, well, lots of people are at risk for seizures, but we don't keep them in the hospital forever. Otherwise, actually, anyone with an epilepsy disorder would just live in the hospital all the time. So like, maybe we want to think about, you know, just because a baby might have a seizure is not actually a great reason to keep them in the NICU. So I appreciate that lens. So that's sort of the first chunk, is like the history of how they came to do this. These babies have been in the NICU for a long time. It's really hard on everybody. We've always talked about, like, there's pharmacological medicine. There's all the, you know, little tinctures and droppers that babies can get, but then there's this non-pharmacological medicine. And what if we actually said, mom is the medicine? So that's sort of the philosophical beginning of where this Eat, Sleep, Console came from, and what I would like for you all to keep in mind. We're going to jump to some things that they then noticed that they had to change in their hospital in order to make this sort of mom as medicine work. And again, I don't expect any of you all to go in and start rearranging hospital beds, though, you know, have at it. But more so kind of, how can we support the parents we see? What can we notice in the hospital settings that we may go in? What can we talk to parents about before a baby is born that might be helpful? Where can we be advocating and speaking up about what we know is best for babies? So here is let me get my scroll in the right place here. Dr. Grossman talking about sort of what he noticed, and this is just about his hospital.
Oh, and if we look at and there may be something more about that. So this is the website photo of our NICU. We just, by the way, built the most beautiful new NICU, but that opened in January. And so for most of the time, we've had this one, and everyone looks relatively happy. This was when I actually snuck in and took a picture. And so you can see the nice place for the family to sleep, and oh no, there's that one chair with the tape on it. So there's this, like, if you could imagine a place that was less friendly for a parent to come, you might design this, and you can think about. So remember, the first line treatment is non-pharmacologic care. So what of those things can you deliver in this situation? They're going to sit in their isolette. They're going to be in this loud place because there's 12 babies going on. There's beeping. There's everybody working. So it's loud, it's bright, it's bustling. No one's there to hold them. They're being fed every 3 hours, so you can swaddle them. That's it. That's the only non-pharmacologic care you can give. First line treatment, and we have sent them to a place where you can't deliver it. So imagine you have a situation, and the parents can't stay. They can't even be in the room when you round because of HIPAA things. We got to round around, and you're going to talk about all the patients, so they can't even come in. And when they do, they can sit in that little chair and kind of stare at their kid. So imagine you had a kid with pneumonia. and they came into the hospital, and you had one unit that they don't carry antibiotics, and you have another unit that does. This isn't a trick question. Where do you send the baby? Okay, so we said our first line treatment is non-pharmacologic care, and we have one unit where we can't deliver any of that, and one unit where we can. Let's send them to the unit where we can't deliver that. So you would never do that in any other disease process. It's listed as the first line treatment. We've now shown that it really works. So we said, okay, next, why don't we not send them there? Because our general unit, not that nice, and this actually isn't even a picture of it, but this is kind of what it looks like. We have single, some double rooms, but either way, at least one parent can stay. There'll be a bed there for the parent. There's like a refrigerator. They can move in and they can be there all the time, or somebody in the family can be there all the time. So we said, okay, here's what we're gonna do. We're gonna not have these kids go to the NICU, and we're gonna transfer to the general inpatient unit. What we're gonna do actually is when they're born, instead of sending them right to the NICU, we'll send them with the mom. And we said mom is the treatment, so they stay wherever mom is. So they go to the nursery, mom stays in the nursery. They stay in the nursery together. And it only took 18 months of negotiating to get our nursery to agree to do that, because they weren't having to deal with these families, and they didn't want to start. So they seemed like that was a lot of kind of a big headache, and nobody had really nice things to say about these families. So some thought it was a good idea, but a lot of people were really resistant to it. And so the deal was once the babies started to have withdrawal signs, so they started learning how to do the Finnegan scores. Once they hit a score of 8, they could send the kid down to our general inpatient unit, to me, and then once the mom was discharged, he would follow. And if the kid had another medical problem, they would send the kid to the NICU. And so the first 6 babies that we had all had another medical problem that caused them to be sent to the NICU, which all resolved within the first few seconds of being in the NICU. Who knew? So there's a little bit of a protest vote with that. And then I'm going to come back to them because the change in culture there has really been remarkable. So, but the idea was now we're just going to keep the baby and mom together. And then, and so the babies would sometimes come down and the moms would follow shortly after, but most of the time they came down together. Next. Okay, and by doing that, now keeping them together, we were down to 10 days as a length of stay. And so you will see, though, you see.
I'm pausing it here. I'm going to pause because he goes into a little sidebar then about the data on that graph and some of the babies that went to the NICU. He said that we actually happen to have not very many babies in the NICU then. And so we think the NICU was kind of like holding on to the babies longer. So that's why some of them stayed longer. But he's like, what his point is like, just by this little bullet here, transferring moms and babies together to the inpatient unit, and making sure that we're doing the non-farm care, doing the swaddling, the holding, the things that we can do. We've gone from 22 days in the NICU down to 10 days in the NICU. And one of the things he talks about that I think is important is he's like, me personally, like, I'm sure the hospital cares and insurance companies care and money counters care about how long they're in the NICU. He's like, I don't care. If a baby needs to be in the NICU, they should be in the NICU. It's not that I want that length of stay to be shorter because I care, but because it's so hard on families. And I think we probably all have had the experience of watching a family try to care for a baby in the NICU. And as he mentions, like there's one plastic chair and you get to stare at your baby and how incredibly hard it is. So he's sort of saying, I'm not saying like the stay because a baby shouldn't be in the hospital if that's where they need to meet, but I'm saying it is so hard on families to arrange transportation and childcare, to get out of programs if they're in them, to actually be able to really do the kind of care that we want families to have and to bond with their baby and to have those first few days with their baby. And he keeps saying it, right? Mom is medicine. And if we know the mom is medicine, then why would we send the baby to a place where like that medicine can't be? So the last little piece we're going to see here, just about 3 more minutes, just sort of talking about what he noticed in his hospital. He touched on it there. You don't know if people heard him say, like, there was some pushback amongst the nurses who were kind of like, we want to take the babies and deal with them ourselves. We don't want to deal with these families. There's some language there that he is acknowledging was a problem in his hospital. And again, we can't change the culture of an entire hospital, but we can speak up. We can talk with the parents we support. So I'm going to show you guys sort of what he found about the culture in his hospital when I jump to the right place here. All right. And this part, he's when I jump it in, he's reading a quote that a mom shared during a qualitative interview study. And he's just sort of pointing out, the poignant language that this mom is using and sharing how her hospital experience was and what they're trying to do in their hospital.
powerful for us. If you're using while you're pregnant, you have a problem, a big problem, and need help. You obviously don't care about yourself, about anything except the drug. Make it a little bit easier on that mother if she's showing initiative. If she's taking the time to be there, if she loves her child, you can see it and you can feel it. If it's obvious that she's there for the baby, then embrace it, make it easier. You don't know what her circumstances are. You don't know what she's been through or how hard her life has been. You don't know what she was feeling when she was pregnant, if she was being abused, if she was poor, whatever the reason she was using while she was pregnant, you don't know. So try to make it easier for her. So we said, yeah, that seems reasonable. We can try to make it easier instead of making it harder, which is what we've been doing. We had taken this vulnerable family and made their experience much harder than every other family that came in. Next. So we said, we got to do this better. And so we realized our role was more as like a coach and a cheerleader. So we weren't doing very much medical stuff anymore. And so really what we weren't trying to lower our length of stay. We wanted this to go well, not just in the hospital, but when they went home. So initially when we were discharging these kids, it would be 28 days, and we would say, all right, you ready to go home tomorrow? And the family would be like, we're not ready to go. What, are you kidding me? We don't have a crib. We haven't done anything. And we'd be like, hi, it's been 4 weeks. How is this possible? And so what we're doing now is the parents are doing all the work in the hospital. So we're able to work with them about what strategies and what's working and what's not, and help them through it. Instead of thinking about what we used to see is that, well, we'd hear a nurse say, the mom looked really sleepy, so I called Child Protective Services. They're like, yeah, well, her methadone dose is 30% higher than it's supposed to be. 100% of moms going through that are going to be sleepier. So let's try to figure out how to work with that and discuss that with them and figure out how to support them. Say, you're doing great. Usually the baby eats at 3 a.m. Why don't I do that feed for you? And then you can sleep a little bit more, like we would do with other moms. So our third tenet, remember we got mom is antibiotics, pretend it's a baby, pretend it's a mom too. Do the same things you would do for any other mom. Support them the same way. It's why people got into this line of work, not to be mean to people, so support them. There are times where the parents just aren't there. And so what we found is that does not change what the baby needs. The treatment for this is really simple. It's pretty much just love. And so if the parents can't do it, then we got to figure out how to deliver it some other way.
I'm going to pause it there because there's just something about that last sentence. Pretty much what we need here is love. It gets me choked up, and I've seen this video 100 times. I'm going to stop the share here, come back to our PowerPoints, go over a couple of things that might be helpful to think about when we're supporting families, and then put us into breakout rooms so that we can engage with each other around what can feel helpful as we're supporting parents. So go back here. Okay. All right. So I'm sort of going back through the things that I heard in the video again, with some science behind it. This is what it turns out Eat, Sleep, Console looks like. This is what it turns out can lower length of stay, have parents who are feeling like they have that loving connection. And there's really 4 things, and we can help parents think about how to do these things. And as he says at the end there, if they can't, for any reason, without judgment, if they have 5 other kids at home, if they're in an IOP from 9 to 5, if they are living on the street and don't have a way to get to the hospital, whatever it is, we can help the parents that we support and think about how to give these things for their babies. Offering comfort right away. Again, if you can't be there, who can be? Do you want to talk to the hospital about whether there's a cuddler, whether there's someone that can be there from your family that you love to offer immediately? Like he was saying, when you have a baby in the NICU and they've got 15 babies and one of them needs some kind of fancy central line, they can't necessarily get to your baby right away when they're crying. And that's not because they don't care. It's because the NICU is set up for do the emergency things first. But we know babies do better when they get care right away. How can we learn my baby's hunger cues and respond to them? We could do a whole nother webinar focusing on the benefits of breastfeeding when that is something that mom is comfortable doing. I'm a big believer that sort of the best way to feed your baby is the way that mom feels is the best way to feed her baby. If we can help a mom see that breastfeeding is something she can do and feel successful at, that is supporting better outcomes. One just cool piece of research I found on this, I don't think it'll be surprising, but actually Davida Schiff, who's one of our colleagues at Mass General, and some other doctors have done some research recently, really looking at what is it that helps moms, particularly moms in recovery, consider initiating breastfeeding, because the rates aren't really, really high. And so they kind of wanted to know, like, well, why is that? And what goes wrong? What do moms say? And one of the biggest things that they found is that moms know, like, yeah, I know it's probably healthier for my baby. And I know that, you know, if I've been, let's say, stable on my treatment for a long time, it's something that I can do. But I'm really worried about how the stress of it and the physical pain of it is going to impact my recovery. And I think that that's so important for us to name and talk with moms about, again, not to say that our goal is to get every mom breastfeeding. It's not going to be right for some families, but to at least be able to talk about it. And moms are really able to say, when we ask them, hey, what might help you? Well, it might help if someone was like comforting me or consoling me or telling me that it was going to be okay. I might have been able to get through it a little better. The quiet and the low stimulation environment is something I really want to advocate for us to be thinking about. We have talked about like using funds here to buy noise canceling systems, to buy light blocking blinds. What are the things we can do if a mom's living in a residential program that isn't maybe set up the way that we would wish? How can we help a parent to think about that? And that really babies need that physical support and that connection, that closeness. Again, if a hospital's doing rooming in, that's great. If not, hey, can we be that nudge that's like, oh, gee, let's bring the rocker from that side of the NICU over to this side of the NICU. Like, how can we be an advocate and a partner with the parents that we are supporting? So with all those things in mind, I think we'll take just about a 5-minute break here. Adrienne has us sorted into breakout rooms just to share with each other. Again, none of you are going to become neonatologists tomorrow. Props to anyone on this call who might be a neonatologist. But all of you can support parents in thinking about, how does this video hit you? What's the language that you hear? What are the tools that you hear that you want to bring as an evidence-based practice into the work that you do? So Adrienne, I'll pass control over to you.
Great. All of the rooms are open up right now, and they'll close automatically after 5 minutes.
Perfect. Okay, so hopefully you all had some opportunities to just share with each other and think about sort of how might taking this evidence-based practice, this thing that's been studied by millions and millions of NIDA dollars and hospital dollars, be helpful to the parents that I support. Just a quick minute, if there's anything that someone feels like they're bursting to say, I invite you to share for yourself. We don't out other people, but if there's anything that someone feels really called to say, we can take a minute to do that before we move on to our next intervention. Okay. So here's the thing, right? We talked about sort of what infants really need is to be responded to when they're hungry, responded to with care, responded to quickly. And that might sound easy, but it's not always easy. And particularly if a parent is going through a lot, has had their own trauma history, was not parented the way that they might have wished to be parented, it can be hard to kind of figure out, how do I respond to those cues quickly? What do I do with my own feelings? What do I do if I know that maybe my baby needs something, but I'm not sure what, and that feels really scary or really overwhelming? So the other evidence-based intervention that we're going to borrow just briefly from, again, just to give you some framework when you're supporting parents, is from the Circle of Security Parenting Intervention. And this is very, very widely used. It's a video-based intervention. So you watch videos and then you're in a group and you talk about the videos together. And it's giving parents some tools to think about the needs that children express. All children, universally, all over the world. But what I want to show you, and we'll watch just a couple minutes of video of this, is the concept, because I want you guys to hold on to the concept as you're thinking about supporting parents. There's a couple of things. This graphic here, this graphic in the middle of the slide, they call it, that's the circle in the Circle of Security, right? It's like a little more like an oval, but I think oval of security sounds weird. So they went with Circle of Security instead. And one of the things I want to sort of point out to you that I think is really interesting when we think about this intervention is the parent is not in the middle. The parent is actually not like right in the middle of the baby's world. The parent is over here on one side, supporting a baby or a young child in a secure base. Think of like the base of a table or the base of a building. When the baby is going out away from the parent, and that could be physically, if the baby's crawling, you see the little baby in the graphic is crawling, but it could also be with our eyes, with our attention. So parents are there to support babies when they are needing a little bit less attention, because their attention is focused on, do you see on the right side of the screen here, their world. So babies shift their attention between their secure base, their parent, and their world. And they go and they explore and they look at new things and smell new things and touch new things. That's all part of healthy baby development. And then when the baby needs it, they come in closer to their parent. Again, if they can crawl, they might scooch closer. If they're using their eyes, they might bring their gaze back to their parents. They come in for connection, for safety and reassurance, not forever, just long enough to when they feel okay and they can go and explore the rest of their world again. So this balance and this idea of a circle and that babies move around the circle is sort of the foundation of the whole circle of security intervention that it would take 8 weeks to explain. So we're not going to do that. But what I want to show is a little bit of video where they just talk about how babies show us if they're feeling okay and what we might see, and if babies are not feeling okay and what we might see. And I'm going to talk a little bit about sort of how we can support parents if they seem to be finding it a little bumpy to follow their baby's lead along that circle. I'm going to say something. We all find it bumpy to follow our baby's lead sometimes. All of us, every last one of us has moments. We have a headache. We don't feel good. We're distracted by our other child. We're distracted by our boss, that we struggle to follow our babies in that in, out on the circle. But when we're doing well, we're able to notice if our baby needs to explore the world or if our baby needs a little comfort from us. So I'm going to pause our screen share here while I switch over to our video from Circle of Security. For those people who have maybe seen this intervention, again, these videos are what is used for parents. So when you run this group, you're kind of showing parents these videos and talking them through, and you'll hear the video facilitator. She's going to say, like, pause the video here and talk about this. And we're not going to pause, and you don't need to talk about it, but just so you know, that's where the cues are coming from, is because this is a video that's designed for parents. But we're going to watch it just together, just to get an idea of, again, this is what we know helps parents be responsive caregivers. And sorry, I just got to look at my minute by minute cue here and make sure that I've got the right place. 5:27, perfect. All right.
This step has to do with how our babies are feeling. Here's the question we want you to be asking. Is she or he feeling okay or not okay? It really is that simple. So here we go. With this next clip, follow along with the baby's feelings.
What do you think? Look at Mama's hand.
Pause for a moment and talk about what you saw. Sometimes babies turn away when they are not feeling okay. They still need to be close, but they seem to be saying, "Wait with me while I learn to soothe myself." It will serve them well throughout their lives to both get help with feelings when help is available and be able to manage feelings by themselves when they need to. Our being with them as they learn to soothe themselves helps them to carry our support with them throughout the rest of their lives, even when they are on their own. This is a baby who's not feeling okay. She's looking down, as if to say, "Wait with me while I learn to soothe myself." Looking up and seeing someone is being with seems to help. Watch one more time and notice how her eyebrows and the breathing of the person sitting with her show how connected they are.
Yeah.
Even as she's learning to soothe herself. And here is one more.
Oopsie.
Pause for a moment and talk about what you saw.
Okay, we're gonna pause for a long moment. And in the interest of time, I just want to say sort of some of the things that, again, you might pick up on there that you might want to share with the parents that you support. And one of the things she says at the beginning is, like, one of the ways that babies kind of move out when they're ready to explore is they turn their gaze out. And sometimes when they need our help soothing, they don't necessarily turn their gaze right back towards us. And that's a long, complicated thing about the neurobiology of babies and babies' brains. But she says they still want to be close. And I love the idea of supporting a parent to maybe be able to have a hand on on a car seat or a bassinet, or have an arm, even if a baby is sort of not able to share gaze. And I think for so many of us, and especially if we're feeling overwhelmed or sad or guilty or worried, if our baby shifts their gaze away, right? In adult communication, if someone shifts their gaze away from me, it often means I'm not interested. That's not actually what it means for babies. They're still developing their coordination to be able to look and take in at the same time. And I think it can be really helpful to share with parents. Maybe you're wondering if your baby, is not wanting to connect with you, not wanting to be with you. I wonder if there's a different way of thinking about this. So I invite people to take that with them. The physical closeness, it's hard to be with that cry, right? When we hear a baby cry, for all of us, it can be a lot to deal with. So as much as we can talk about what the evidence base says we should do, I think it's also important to talk about sort of what do we do when it's hard to be with a crying baby, whether that's in a nursery, whether that's while we're still at the hospital, whether it's when we've come home. Again, this is that universal design. It could be that this baby is having a harder time soothing because of withdrawal from a substance. It could be that this is a baby who has a hard time being soothed from some other reason. And really just helping understand what our role is in soothing cries. So I'm actually borrowing this. I'm sort of sneaking in a third evidence-based intervention for those who are curious. Helping parents with babies who are crying a lot is something that we've also studied out of the University of Chicago and the Erickson Institute. And they created an intervention that they call Fussy Baby. Their real focus is when babies are fussy, they're having that period of purple crying, that colic, substance exposed, whatever. We know how to help parents be okay in those moments. Because that's the thing, right? We're relying on parents to be the medicine. We need the medicine to be okay. We need the medicine to be feeling all right. So I'm going to name 4 things. And then we're just going to throw up a real quick poll just to see what people think, where you might have the biggest role in supporting the parents we see. So I'm going to say 4 things. Okay. The 4 things that parents need when babies are crying. They need to be able to calm themselves, slow their own selves down. So sorry, that's 2. Calm themselves, slow down. You can hear in my voice, just slowing down. They need to be able to think creatively, to come up with solutions. Tell parents all the time, if there was one way to help a crying baby, there'd be one book about helping crying babies. There's about 100 books. There's a million different solutions. So you got to be able to think creatively, and you've got to have kind of the patience to try different things, because there's a million solutions and the first one's not going to work the first time. So those are, and there's probably more, but those are what Fussy Baby tells us are like key things. I got to be able to calm myself, slow down, think creatively, and try different things. We just thought we'd throw a poll up there and just see what people think in this group. As you support parents, which of those do you find is like, oh God, I really got to get in there with this one. I've really got to be able to support parents with this one. For people who haven't used what are we using? A Zoom poll before. These are anonymous. I'm not going to see your answer. I'm not going to know, I'll see the answers, but I won't know what you clicked. So I invite people to just think back, think about those cases I invited you to hold in mind. What's the most important place that I need to support the parents that I care for? And let's see. I think that's, Adrian, I think you can see when it's mostly answered, but I'm actually not sure.
Yep, I see people answering it now.
Okay, perfect.
Here we can show the results in the interest.
Sounds good. Yeah. Okay, so this is really, this is exactly where I wanted it to be. I couldn't have paid you guys to do it better. I'm gonna be all the way honest. As a home visitor myself, especially earlier in my career, I wanted to jump to trying different things. I wanted to, well, have you tried? Well, have you thought about? Well, I read this one time. Well, there's this cool thing. And the thing is, we're all saying that's not actually what the parents that we support need the most. What they need the most is that help in calming themselves. And we can do that. As humans, we are wired to feel calm in the connection of other calm people. We talk all the time about how the parents that we support feel our calmness, our presence, our connection, and that is helpful. How can we help parents to keep that with them when we're not there? The sound of a voice, a smell, a touch, a lotion, a something. Just like I want a baby to have a blanket for when mom isn't around, I want the parents that we support to have a little bit of something calming when no one else might be around to calm them so that they can feel that calmness. So I take that from Circle of Security. Our babies can show us when they're not okay. They do that by crying. That's not easy. And the fussy baby approach gives us some tools for thinking about what it is that parents need. And most often, it's they need help in feeling that calm. I'm going to take a couple of minutes here just to review a couple of other tools and then talk about some resources and thinking about older children's needs. So I am holding, whoops, well, my blurred screen is not helping. I'm holding the family portfolio that First Steps Together has created for families. If you're not part of First Steps Together, we can throw a link in the chat for where to download the pages of these. But I just wanted to give a couple of examples for those of us who are using these with the families we support of where you might find some particularly useful pieces that tie right into supporting newborns who have been impacted by substances. So if you're following along at home, or you can see on the screenshots there, page 11 really starts talking about families' own understanding of their wellness. I'm going to read some of the language. I can tell I'm starting to feel stressed when my coping skills for managing stress are. This is what I can do when stress is overwhelming me. So here we have spaces for us to support parents in really reflecting on that ability to stay calm so that they can calm and soothe the infant that they're with. If we have the opportunity to connect with a parent prenatally and really say, staying with a crying baby can be really hard. And what they need is us to stay with them. So what can I do to support you in this? Maybe it's connected to that breastfeeding, right? When I need some coping skills because this isn't physically comfortable, I'm not feeling great. What are the things that I need to feel okay? It's such an important part of supporting substance exposed newborns. I think if mom is medicine, we got to make sure the medicine's feeling okay. And then flipping to the section on child safety. This is page 18. And again, just sort of thinking about what's highlighted here is really what I know about my child. This gets into kind of what my child likes to be cared for, who can stay with me or my child. And again, if we have the opportunity, even prenatally, to ask a parent, who are the people who can stay by your side? Who are the people who can stay by your child's side if you need to go and get your methadone dose or be in your IOP for 3 hours, or you just need a break? So really helping parents think about who's in their lives and who might be able to support them. And then last but not least, and now I'm on page 27, but this is also throughout the recovery guide, are spaces to invite parents to journal about their thoughts and feelings. And just like we know that being with a child in distress is the most important thing for that child, being with a parent in distress is the most important thing that we can do. And really helping a parent to be able to talk about when they feel vulnerable or overwhelmed or scared or guilty or filled with shame. Those are the places where we know that we can step forward or we can invite parents to lean into the supports that they do have. Couple of things to think about in terms of resources and how you can support parents. I mentioned the room darkening shades and noise canceling. Every baby who receives a diagnosis of neonatal withdrawal or who is identified as a substance exposed newborn under those guidelines that I read from the state of Massachusetts is eligible for early intervention. We all know that filling out that one page and sending it over to an early intervention provider is often not enough. Wait lists are long. It can be hard to stay in touch. We can have a role in really helping parents connect to early intervention. And I know we have other webinars really focused on that topic. Again, just to cite Dr. Davita Schiff over at MGH, she is doing really great research looking at the impact of sleep on reducing fatal overdose deaths in moms. So she's really connecting that moms need to sleep in order to be able to be healthy and alive and okay. And so what can we do to talk to parents about who can help them with sleep? It is one of the hardest problems to solve. I am not here with any magic solutions, but just really emphasizing that that's something that's valuable to talk about, to think about, to brainstorm around, to do what we can. If you have financial resources available to you through the agency you work with, donations, a particular donor, there are swings that seem to provide some of that physical comfort that infants can do better with when they're having neurobehavioral differences. And anything we can do to support swaddling, that little baby on the bottom right here is swaddled. When Dania and I teach parents, we actually show a video on how to swaddle. You can look it up on YouTube. A really nice, snug swaddle can go a really, really long way. One of the things we learned is that oftentimes parents will be like, yeah, I swaddled my baby, they don't like it. And I'll be like, oh, do you want to show me? And the swaddle is more like, well, I kind of put a blanket around them. A really snug, tight swaddle can be something that feels very soothing. You can ask, you can work with parents. Could we ask your pediatrician? Could we work with, next time that you do have to go for a checkup, someone could show you, like, how can we help parents ask for the support that they might need? And we know that for some babies, because their tummies can be a little bit upset, having really sensitive formula, and again, helping parents to advocate and not feel like my concerns about my baby are being dismissed. So there are things that we can do to help the physical states of babies, and we can be advocates. We can come alongside our parents. But again, the research and our own experience is telling us sometimes it's not like the answers that parents need. It's that calming and co-regulating and thinking together about what might be helpful. I want to take just one word here and say that, as I said at the beginning, is kids are babies and then they grow up. Two things that I wish we could take home from that. We know that there are 2 and 3 and 4 and 5-year-olds out there who are having difficulty with their neuroregulation, with their body feeling okay, their sensory input feeling okay. And there are specific things. We have other webinars. We can talk a lot about what it is that we can do, but it's really similar to what babies need. Less stimulation, quiet, calm, consistency. And again, when we do those things, when we offer those things, it's not going to hurt any other kids. So when we think about how we use white noise machines or soundproofing or quiet spaces, we're supporting all kiddos. When we notice that kiddo who has a hard time at music time or, when in the echoey room, and think about how to reduce that so that kids are getting a little bit less stimulation. And the other thing we know about older kids and all parents, they are built to feel calmer when the person with them is calmer. That is how our brains are built. There's no getting around it. So any intervention that you can offer to support a caregiver, maybe you meet that child's daycare provider one day and you're offering a little bit of caring and kind and reassurance, anything we can do to help build calm for the people who care for infants, substance exposed or otherwise, is definitely helping children to feel calmer. It's helping their brains to feel calmer. And one thing I like when we're, thinking about older kids and going to school, and maybe this little girl on the right is going to school, we cannot learn when we are not calm. So we have to go there first. So with just a couple of minutes left, I want to make sure that we have time for questions. If there's anything in the chat that has come up, as well as I know that Adrian and Maytal will wrap us up for the day.
Yeah, so thank you, Amy. We just really want to thank you for this presentation today. I've, learned so much here. This was so great. We really appreciate having you. Maytal is going to put an evaluation in the chat so that if you have the opportunity to fill this out, that would be great. Also, if you would like any more information about the family portfolio or to other access to our other webinars, you can do that from our website, which was put in the chat, but we can put it in the chat for you again, or you can reach out to Nahia or anyone on the TA team for more information. So again, thank you all for coming today, and thank you, Amy.
My pleasure, always a pleasure. People can feel free to reach out if other things come up. It's all recorded. It's all there for everyone to learn from.
Yeah, and we'll send this recording out along with the slides for everyone afterwards and some resources to help support parents supporting newborns.